Welcome back to PLAB Talks. We're continuing our focused series on headache.
Okay, now we move into really critical territory. Recognizing red flags is absolutely paramount here.
Yes, high stakes now.
Patricia Jenkins, 6-year-old lady, comes to the ED. Headache severity 9 out of 10. She says it's the worst headache of her life. Light is bothering her eyes, photophobia again, and she also has neck pain or stiffness.
Okay, worst headache, neck pain, photophobia, alarm bells.
Then Emma White, also 60, 3-week history of a one-sided headache, scalp tenderness, hurts to brush her hair on that side, jaw pain when she chews, jaw claudication, and she has either noticed reduced vision or is very concerned about it.
Right, 60 years old, unilateral headache, scalp tenderness, jaw claudication, visual concerns.
What immediately screams red flag in these two cases? What are your provisional diagnoses?
Okay, for Patricia, that phrase, worst headache of her life, or thunderclap headache, is the absolute classic textbook red flag for a subarachnoid hemorrhage, SAH. You have to assume SAH until proven otherwise.
Okay, SH for Patricia and Emma.
For Emma, her age, over 50, the new onset one-sided headache with scalp tenderness, the jaw claudication, and especially the vision concerns. This constellation points very strongly towards giant cell arteritis, GCA, also known as temporal arteritis.
Right.
Particularly, she also reports associated symptoms like muscle aches and stiffness in her shoulders and hips, suggesting polymyalgia rheumatica, which often coexist. A high ESR or CRP would further support this.
And the key takeaway?
The crucial nugget here for you is that both of these SAH and GCA are extremely serious. SAH is life-threatening. GCA is sight-threatening. Both demand immediate, urgent attention and management. No delays.
Given that urgency, let's take SAH first. What's the immediate management pathway, key investigations?
For suspected SAH, after your immediate ABCDE assessment, airway, breathing, circulation, disability exposure, just to ensure the patient is stable.
Stabilize first.
Always. Then, immediate admission under the medical team is essential. They need close monitoring, neuro-obs, cardiovascular monitoring.
Right.
You provide adequate analgesia, antiemetics if needed. Arrange routine blood tests, FBC, UNE, LFTs, coagulation screen, and critically, an urgent non-contrast CT scan of the brain. That's the key first investigation.
What if the CT shows blood?
If the CT confirms bleeding, confirms SAH, then it's an immediate referral to the neurosurgeons. They need to be involved straight away.
And if the CT is normal, but you still suspect it?
Great question. If the CT is normal, but your clinical suspicion for SAH remains high based on the history, then a lumbar puncture is needed.
Lumbar puncture. When?
Ideally, it should be performed at least 12 hours after the onset of the headache. This allows time for bilirubin breakdown products, the anthochromia, to develop in the CSF if blood was present. That's what you're looking for is anthochromia.
Okay, clear pathway for SAH. Now for giant cell arteritis, GCA, what's the critical investigation and the treatment, given that potential rapid impact on vision?
Right. The immediate question for suspected GCA is how do we confirm it, but more importantly, how do we prevent irreversible vision loss now?
Yes, vision is key.
Investigations include comprehensive blood tests, FBC, UNE, LFT, blood glucose, and critically inflammatory markers like ESR and CRP. They're usually markedly elevated, though a normal ESR doesn't absolutely rule it out.
Okay, what else? Ultrasound, biopsy.
A Doppler ultrasound of the temporal arteries can sometimes show characteristic signs, like a halo sign, but the definitive diagnostic test, the gold standard, is a temporal artery biopsy.
Taking a piece of the artery.
Exactly. A small piece of the temporal artery is removed under local anesthetic and examined under a microscope for characteristic inflammatory changes.
But that takes time, right? Biopsy results aren't instant.
Precisely.
Yeah.
And this is the true nugget for your practice. Immediate treatment is paramount and absolutely must not be delayed while waiting for the biopsy or its results.
So treat first.
Treat first, diagnose definitively later if needed. This means immediate admission, good pain relief, and starting high-dose steroid medication, typically prednisolone 40-60 milligrams daily right away, straight away, to reduce that inflammation and protect their vision.
High-dose steroids immediately. For how long?
This steroid treatment might be needed long-term, potentially weaning very slowly over 2 to 3 years, guided by symptoms and inflammatory markers. And we usually add aspirin 75 milligrams daily as well, because GCA increases stroke risk.
That's a long time on high-dose steroids initially. What important side effects do we need to counsel the patient about and monitor for?
Yes, long-term steroids, even if the dose reduces over time, can indeed have significant side effects. Careful monitoring and thorough patient education are vital.
Such as?
Well, things like hypertension, inducing or worsening diabetes, osteoporosis.
Right, bone health.
Definitely. For which bisphosphonates, like alendronic acid, might be given as prophylaxis, along with calcium and vitamin D. Peptic ulcers are also a risk, so we often co-prescribe a PPI, a proton pump inhibitor, for gastric protection.
Okay.
Patients absolutely must be educated on these potential side effects: weight gain, mood changes, skin thinning, increased infection risk, and advised to return immediately if they experience any problems or, crucially, if their vision worsens despite treatment.
Okay. Phew.
Thanks for tuning in to PLAB Talks. We'd love to hear your feedback, and we'll be continuing the headache series in the next episode. Stay curious, and see you soon.